Good morning, everyone. Myself, Dr. Pankaj. I'm a pediatrician by profession and teacher by passion. Today we are discussing this amazing series. Welcome you all in Pedia Academy by Pediatrics, Pedia Academy by Dr. Pankaj. So today we are discussing the important topic of this amazing series of NEET SS previous year's topic discussion. Today's discussion is on esophageal anomaly. Mainly, we will focus on esophageal atresia. So, without further delay, let's start the topic straight away. Tracheoesophageal fistula. So, esophageal atresia is the most common congenital anomaly of the esophagus. Important thing is there that this is esophageal atresia. So the question is, which is most common congenital anomaly of esophagus? It is not tracheoesophageal fistula, it is esophageal atresia. The point to be noted here, though 90% of esophageal atresia cases are associated with tracheoesophageal fistula, but the correct statement is this, and we have to mark this. These are two statements which are very important. So most common esophageal atresia is type C. We will see later. Okay. So this is classification of esophageal atresia. So this is normal anatomy and B, C, D, A, E. Just remember it is not starting with A. So first we will see what is A. A is pure esophageal atresia, no anastomosis. Okay, so if someone asks you what is esophageal atresia type A, it is actually pure esophageal atresia without any tracheoesophageal anastomosis. Okay, back to type B. This is esophageal atresia but proximal tracheoesophageal fistula as we can see. Type C is distal tracheoesophageal fistula, and this type C, as we discussed earlier also, this is most common. So most common type. Type D, when both proximal and distal esophageal fistula are there, this is type D. And type E, there is tracheoesophageal fistula but no esophageal atresia. So this is very important in this type A pure esophageal atresia, and type C with distal esophageal fistula is most common. So this is actually the important thing. Next, as you can see, tracheoesophageal fistula, one try to pass NG tube, it is not getting passed and it get coiled in that esophagus. So this is tracheoesophageal fistula. H type of fistula, this actually fistula presents later in adolescence or in adulthood. So this presents with recurrent pneumonia. So this is the pathognomic of H type of fistula. We can see in this lateral X-ray. This is H type of fistula. So, my dear friends, what are the risk factors you have to remember? So, in these risk factors, advanced maternal age, European ethnicity, maternal obesity, low socioeconomic status, and tobacco smoking during pregnancy. These are non-specific, but these are actually associated with this tracheoesophageal fistula, or you can say esophageal atresia. So survival rate, as we know, more than 90% is survival rate unless it is not associated with any abnormality. Okay, so infant are at high risk or like less than 1.5 kg of high risk. So 50% of infant are non-syndromic. So 50% of infant are not associated with any anomaly. Some syndromes are associated with this esophageal atresia. So these are Vector syndrome, Feingold syndrome, Charles syndrome, anophthalmia esophageal genital syndrome. So these are syndrome. So if someone asks you which are the syndromes, then you have to tell this Vector syndrome, Feingold syndrome, Charles syndrome, anophthalmia esophageal genital syndrome. So these are 3 or 4 syndrome which are associated with esophageal atresia. Okay, what are the features or presentation of this condition as we all exposed to this condition? Frothing and bubbling at mouth or nose, cyanosis, coughing, respiratory distress, polyhydramnios in ANC finding, and aspiration from TEF can cause pneumonia. And so this is the main common presentation of this condition, which is very, very important. We have to remember. If it is H type, in H type the presentation is different with chronic respiratory issues such as refractory bronchospasm and recurrent aspiration pneumonias. So in H type this condition is seen. Okay, how you will diagnose or suspect this condition? If polyhydramnios in ANC is there, inability to pass NG tube and fetal imaging is not used, but it is the entity there, we can use it. X-ray, we can see the coiled tube is there in esophageal pouch. Okay, pure esophageal atresia may show airless scaphoid abdomen. Okay, so in pure esophageal atresia, when there is no tracheoesophageal anastomosis, so in this condition, the stomach have no air. So this is important statement and also differentiating statement. Pure esophageal atresia is also called as type A esophageal atresia. So what is the investigation of choice in H type? Esophagogram with contrast and bronchoscopy or methane blue dye during endoscopy can identify this orifice. So management, obviously conservative management like ensure patent airway, decompress the proximal pouch to prevent aspiration of oral secretions, administration of antibiotics, prone positioning to reduce aspiration risk, and avoid endotracheal intubation. So this is important thing because we are actually do this endotracheal intubation frequently. So just avoid this condition. Surgical treatment, ligation of tracheoesophageal fistula and end-to-end esophageal anastomosis with right-sided thoracotomy. So this is the treatment of choice, ligation of tracheoesophageal fistula with end-to-end esophageal anastomosis via right-sided thoracotomy. Okay, in premature condition, we can do some palliative procedures like fistula ligation, gastrotomy, tube placement. So this can be done. Again, the important thing, if the gap is more than 3 to 4 centimeter between esophageal ends, use gastric, jejunal or colonic segment as neoesophagus. So, if the gap is more than 3 to 4 centimeter, we have to create neoesophagus. So, this is important concept. So, outcome is good. So, surgical complication, as you know, anastomosis, refistulation structure formation. Okay, what are the later conditions which are associated with this condition? So GRD can occur, tracheomalacia can occur. We have to just monitor these conditions. Okay, so early diagnosis, comprehensive care, long-term monitoring is required. Okay, so this is important slide. We will discuss this esophageal atresia and some other anomalies in tabular form. Isolated atresia, as we know, this is type A esophageal atresia. So regurgitation of feeding and gasless abdomen is important esophageal atresia type A finding. Atresia with distal TF type C. This is our classical case. H-type fistula, this is recurrent pneumonia, bronchiectasis, and this presents later infant to adult. Esophageal stenosis is also entity. Esophageal stenosis is there. Duplication cyst, which can cause dyspnea, stridor, cough, dysphagia, vascular anomaly, esophageal ring, and esophageal valve. So these are other conditions. You can see this is congenital esophageal stenosis and this is on esophageoscopy. This is a ring or narrowing. So this was about tracheoesophageal fistula and these other associated condition. We will discuss the important points regarding other topics in this series. So stay tuned and